reproductive structures, okay? So external genitalia and internal reproductive structures, as well as your urinary bladder. Okay. This ganglia, these that run like this parallel to the spinal cord, does anybody remember what those are? We can see them in lab even. You can look at the spinal cord, and on both sides there's this nerve with segments and ganglia that go all the way down. Do you remember? Remember the sympathetic chain ganglia? That's what that is. So you can actually see it. We can dissect it out. You can see it runs right parallel to the two sides of the spinal cord. Sympathetic chain ganglia. Remember I gave you that analogy of like people chained together, right, and walking together like a chain ganglia? They're all attached. So these nerves come out, synapse on the second neuronal pathway, and those go out to the various different structures. Okay, so the sympathetic chain ganglia, or trunk ganglia, your book calls it. I like to call it sympathetic chain ganglia, and a lot of other places do, because that's what it is, right? It's a whole chain that has ganglia connected together. So those are allowing the routing of the different nerves of your sympathetic division going out to the different parts of your body. Come out on both sides of the vertebral column, so they're on both sides of your vertebral column, linked by little short nerves into the sympathetic trunks, and we call that whole structure the sympathetic chain ganglia. Okay, so the sympathetic chain ganglia, they actually join to the ventral rami by these structures called the rami communicantes. So they are white and gray, shown right here. Here's the white rami communicantes, and here's the gray rami communicantes. But basically what happens is the lateral horn is where that preganglionic sympathetic neuron is. That's where the cell body is. It exits through the ventral root, okay? Goes through the ventral root, and then it uses those little communicantes, this means to communicate or connect, right? Uses those little communicantes nerves to go through and synapse inside of that ganglia as part of that sympathetic chain ganglia. And then that's where the second neuron is in the pathway, shown with this little dot. That's where the postganglionic neuron is, and it leads through the gray rami communicantes, and then it goes out to the actual effector cells. So the rami communicantes, this part gets a little complicated. We can dissect this and end up seeing those little connections. Basically though, the rami communicantes allows the preganglionic neuron of the sympathetic nervous system to exit and then merge to the sympathetic ganglia and go down to whatever structure it needs to go out and innervate. So it's a pathway to reach the sympathetic chain ganglia. Okay, and either travel down or up to the effector organ that it's serving. In this case, it's skin. It's going out to the blood vessels in the skin, it's going out to the arrector pili and sweat glands in the skin. Okay? So rami communicantes allow the preganglionic neuron to exit the ventral root and then go follow their own pathway to go out to the rest of the body. Okay. Now there's a lot of anatomy pictures on this one page, I realize. There's four different ones right from your book to show you what they look like. So here's all your vertebrae, the bodies of your vertebrae. Here is the spinal cord and the ventral root that leaves the spinal cord. And here are the communicantes, the white and the gray communicantes. Okay? What they do is they allow that axon of that preganglionic neuron to exit and leave, and then go through the white communicantes and basically wrap up through the gray, ultimately letting them go down through the postganglionic or the sympathetic chain ganglia. So here's sympathetic chain ganglia, here's the gray communicantes, and here's the white communicantes. And again, this is the same picture that I just showed you on the other page. One leaves, goes through synapses on the postganglionic neuron, and that goes all the way out to the effector organ. Here showing sort of the same thing, except in this case, it's actually going up to the next one because this one is going to exit out to a higher place out of the body, a different patch of skin, a different set of blood vessels that are higher up. So they traverse in these. They go out, and this one it goes up, and this one it goes out to its actual effector organ. And showing how they do so in this way as well. They exit and go out to their final terminal organs. Okay, so sympathetic and parasympathetic divisions have similar structures, similar mechanics like this, but they have different anatomy of where those neurons are and where those ganglia are. And then the neurotransmitters that they use are also different. Norepinephrine versus acetylcholine. This is just to show you inside your body. If you look in the thorax and the abdominal cavity, all of the different autonomic nerves, plexuses, and ganglia. And I'm not going over all these, we're not going to touch, I just want to touch on this to show you they're really, really complex, they're everywhere. So you have the sympathetic chain ganglia that go alongside of the spinal cord, and on either side of the vertebral column. And then you have a lot of other ganglia all out inside of your viscera, surrounding your lungs, your heart, up in your neck. They're all over the place. So you have these plexuses. Remember nerve plexuses? These are like nerve plexuses for your autonomic nervous system. So web-plex branching areas of where these are going to different tissues. And also ganglia spread throughout your inside of your body. And there's cardiac branches, and there's esophageal branches that go around your esophagus. They're all over the place. Okay, so that is just in general showing how complex all the structures, the ganglia, the plexuses, and the nerves that make up your autonomic nervous system. Highly branched, kind of all over the place. Yeah?
Just like clarifying that pathway where it starts with the lateral horn, does it always go through the gray or the white grayness and then the gray grayness?
Yeah.
Okay.
Yep, that's its location. It kind of goes out one, and then the final one exits out the gray and goes out to the structure. Yep. Okay. So the major organ, so this is an organ that's part of the sympathetic nervous system and arguably the most important one. This is what really allows the bolstering of the effects, like really getting a dramatic effect. The adrenal medulla. So here's the adrenal glands. And anytime in anatomy, remember when you hear medulla, means middle. That's the core. Medulla means core. So if you see the word medulla, or if you see the word cortex, you don't even have to know that organ and what it looks like. You could basically safely say, oh, that's the middle, so I should be looking for the middle, and that's the outside. So here we're focusing on the adrenal medulla. That's the core of the adrenal gland, which is basically an endocrine gland because its whole job, it's actually specialized little neurons, short little neurons, which are like postganglionic cells, and they just become a factory for making norepinephrine and epinephrine. So it's a major organ of your sympathetic nervous system, and it's the largest, what we would call sympathetic ganglia. It's like an enlarged ganglia that has all the cell bodies of these postganglionic neurons just in there making tons of these adrenaline and noradrenaline hormones. So it's like an enlarged ganglion, and it's an endocrine organ. So it secretes high amounts of epinephrine and norepinephrine. And note, these act as hormones. So these act as hormones, that means they travel in your blood and they can act on distant locations. So those distant locations are already getting nerve activation by your sympathetic division, right? Going to your salivary glands, your iris, your heart, your lungs, your skin, your gut, all those different structures. But now you have hormones of that same neurotransmitter, which can act as both transmitter and hormone. Now you have these blasting in your blood. So all those organs are being bathed, essentially, with that neurotransmitter as a hormone. Yeah, so it can reach targets that are far away to really bolster the effects of the sympathetic nervous system. And they're stimulated to secrete by those preganglionic sympathetic nerve fibers. Okay, so preganglionic fibers activate the adrenal medulla, and boom, they dump out hormones right into the blood. So this aids in the stress response. Okay, aids in the stress response, but it also aids in a lot of other things: sex, excitement, exercise, all those things. Your heart rate goes up. Right, respiration goes up, eyes dilate, all those different things are aided by these hormones that are actually surging through your blood now, in addition to the nervous system effects. This is a blow-up of what that looks like, so you can see is the adrenal gland is all here. The medulla is this core, this middle, and it's making, these cells are specifically making lots of epinephrine and norepinephrine. So that when the lateral horn, this preganglionic neuron of the sympathetic division gets activated, pathways coming down from your brain, okay, say, okay, go, get activated. Preganglionic neuron goes here, goes out the white communicantes in this case, goes right through, it bypasses the sympathetic chain ganglia. This one goes right out to the adrenal medulla, synapsing on the core of that. So this is essentially the preganglionic neuron, and this is kind of like the postganglionic neurons. Okay, it's like a modified ganglia. Its whole job is to make these hormones. Now notice with prolonged stress, so this is short term. Everything I'm talking about right now is acute stress. Short, this is fight or flight, this is fast. This is seconds to minutes, no longer than like an hour, usually, maybe more, but usually in a short time frame. If you experience great stress though, the cortex, this outer periphery of the gland, will start to engage and make the hormones it makes. What hormones do you think the cortex, the adrenal cortex makes? If I stay under a stressful climate or situation for a long period of time, where it's more than just the medulla being activated, now I'm activating all the cortex. It's an endocrine organ. take a guess, what other hormones do you think might come from that?
Cortisol?
Yes, exactly, cortisol. Cortisol, the name cortisol, cortisol, that's a major stress hormone. That is when you're under stress, traumatic situation, doesn't even have to be traumatic, just stressful for a chronic or a long period of time. Your body will start making lots of cortisol coming from the adrenal cortex. That's where the name comes from, cortisol. And it's a steroid. It's basically a steroid. So it wreaks all kinds of havoc on your body if you're exposed to too much cortisol, okay? And that's actually stress, and all of that is linked with heart disease and all these other things, okay? So short-term stress is what we're talking about, fight or flight. Longer term, or chronic, that's when this whole organ starts to get engaged and starts to pump out not just epinephrine, but cortisol as well. You can get cortisol in the shorter term, but it's a major hormone release with longer term stress. Yeah, there.
Is cortisol the same thing as cortisone? Because I know like my dad has gotten like cortisone shots. Is that the same thing or is that two separate
Very
things?
similar, very similar. So that is, scientists and medical professionals have capitalized on the body's ability to make these hormones and replicated these hormones. So when you give high blasts, there's prednisone, there's cortisol, those are all what they are is anti-inflammatories. They quiet your immune system down. Okay, so if someone has they're an organ recipient, they're getting a transplant for an organ, or they have some sort of major inflammatory condition, cortisol is a steroidal anti-inflammatory. The cool thing, you bring this up, cortisol, given in its various medical derivatives, those long-term have negative effects on the body. This is why doctors try not to prescribe them too much in a long-term situation. Cortisol, even in your body, starts to make a whole lot of bad things happen. And it inhibits your white blood cells. So it's anti-inflammatory, but it shuts down your immune system in essence. This is why long-term stress leads to sickness. Do you hear that? Long-term stress literally leads to sickness and can kill you. So if you're exposed to high stress, your cortisol, it starts to degrade different tissues in your body, lead to high levels of sugar in your blood, ramp up everything in your body, but yet inhibit your immune system. It quiets your immune system, stops inflammation, so anti-inflammatory, anti-white blood cell, so they can't fight infection when you're exposed to infection. So if you get exposed to the common cold or the flu or the COVID, SARS-CoV-2 virus, you are much less likely to be able to fight it when your body's under stress. Why? Because all the stress hormones are pumping throughout your body, especially cortisol. So we can use cortisol in a good way for an organ recipient with a transplant, with someone with a chronic condition that has inflammation, keep all that down. But long term, it will have very negative effects on the immune system. And even cortisol, like topical cortisol, it's like anti-itch, anti-inflammatory, but you don't want to do too much of that. That's why the doses in those are pretty low. Did you have a question?
Yeah, I was just wondering, does cortisol, is it related to having heart attacks, like high levels of cortisol and?
Yes, stress directly, yeah. And we're gonna get into the heart pretty soon too, yeah. Stress, lack of exercise, poor diet, smoking directly lead to cardiovascular disease and heart attack. Yep, okay. Referred pain, just a map of referred pain. This is talking about different places in your body, in your periphery, that in your insides, your viscera, all these structures that are controlled in many ways by your autonomic nervous system. You're not used to having pain in those places of your body, right? Not usually. Now, if you have a heart attack, that's something hopefully people don't have. But now in our country, like 1 out of 5 people, by the time they're 50 or 60, will have cardiovascular disease and more than likely a heart attack. Very high. The numbers are super high. So inside your body, you have all these visceral motor responses with your autonomic nervous system, but the sensory component, so the visceral sensory, remember pain, stretch, temperature, nausea, hunger, all those inner things, you're not used to having a lot of stuff coming from the inside. That's very bad. So oftentimes what your brain does is it interprets where that pain or that discomfort is coming from. So for example, in a heart attack, see here it's on the chest and it kind of goes down the inner aspects of the left arm. And people always describe that, like arm pain, tingling, they can't feel, they're numb. For men and women, those symptoms are actually a little different. This is why women a lot of times can't feel that they're having a heart attack, or they don't know what it is. They think it's indigestion or acid reflux, because women tend to have it up in their throat, in their jaw, like in their jaws and in their neck, and they take, what's the antacid? They take antacid, stuff like Tums and stuff, and because they think that's what it is. But men typically have the arm. They typically have the chest and the arm. But this is referred pain because what your brain is doing is trying to make sense of where those pain receptors and stretch receptors are being activated, but you're not used to having pain coming from the inside. So for example, an appendix, usually it's kind of in a disc-shaped sort of structure right on your right side of your abdomen. Heart attack, like I showed you here. For things like the colon, kind of just below your belly button. Ureters, interestingly enough, ureters come from your kidneys, which are up here, but where you feel them is down below your groin, like in your upper thighs and your lower part of your groin. Bladder, you feel right above your pubis bones. So this is kind of a map of referred pain, so where your brain is trying to make sense of where these painful situations are happening. So your autonomic nervous system is taking in sensory information, and then it's carrying out, the main branch of it is carrying out those different actions, contraction or relaxation or stimulation and inhibition of these different structures. So what is the control of the ANS? Basically what it comes down to is your cerebral cortex and your frontal lobe is really involved in processing and making sense of information that's coming into your brain. Your limbic system, all those structures that wrap around here, right? The amygdala, the hippocampus, your olfactory bulbs and tracts, your fornix, all those things make your emotional brain, that is actually giving an input as well, right? So you can perceive things. Oh, is that a threat? Is that bad? Is that scary? Is that bad? Yucky? Right? Giving your brain that information so that the right pathway can be activated. Ultimately, the hypothalamus right here is the overall integration center of the autonomic nervous system and the boss. So this sends down pathways through the brainstem, the reticular formation of the brainstem, and down through the spinal cord to control all those different autonomic reflexes, all those pathways that happen. So brainstem reticular formation, regulation of pupil size, heart rate, respiration rate, blood pressure, swallowing, all of that. Spinal cord, there's reflexive pathways for urination, defecation, erection, and ejaculation. These are all kind of controlled by the higher brain and the hypothalamus, but then go down to the spinal cord to activate the different structures. Okay, and when we talk about reproductive systems, we'll go into that a little more. What is the role of the peripheral, or the parasympathetic nervous system versus the sympathetic nervous system? In general, the ANS throughout life, though, it declines a little bit. So the activity, the ability of your autonomic nervous system to work effectively declines with age. That's Forrest Gump, when in the movie when he goes and runs for like years. One of my favorite movies. Constipation and reduced mobility of the GI tract. This happens notoriously with aging. So less responsive to the parasympathetic division and allowing peristalsis and normal GI mobility to occur. Many older people get constipated, right? You hear about them needing their prune juice and their Miralax and eating their bran muffins and their fiber and everything to keep them regular. That's a real thing. That's a real thing because this tends to get less responsive to the parasympathetic division over time. Drier eyes and reduced tear formation. So the lacrimal gland, less productivity and less making of that saline or tear solution in the eyes. Many older people, what they have to do is drops, right? They do eye drops. I hate putting stuff in my eyes. I really hate it. So if I have to do this one day, I'm gonna have to get good at it. Fight or flight reaction, notice, so the sympathetic is still intact, but it may be slower to respond. The individual might be slower to respond. So still fight or flight is pretty quick. Older person, elderly person, he still will respond to loud sounds, to loud perception, but being able to run away might be a little slowed down. But as far as the sympathetic division, it's still pretty active. It's still heightened, able to respond. All right, next section is special senses. We're gonna continue on with the eye and the ear and the general senses. Any questions about where we're at so far? What we've covered? So peripheral nervous system, autonomic nervous system. Now we're going more to special senses. Gabby, can you tell me time? And is that still working?
Yeah, it's still going on, and it's 12:42.
What time?
12:42.
Okay, cool. All right, so I will get out of here and we'll go back to special senses and the eyeball. So, and I skipped over the first part of this section and I just went right to the anatomy of the eyeball, but I want to back up a little bit and introduce the sensory receptors and special senses and how they work. Yes? Okay, all right. So we have a few different types of neurons which are acting as receptors throughout your whole body. We have two major categories, free nerve endings and complete receptors, like receptors that are specialized epithelial cells or they're small little mini neurons. So free nerve endings, actually what they monitor is general sensory information. So general sensations, things like pain, free nerve endings. When you have these complete receptor cells, so this is pain, touch, vibration, temperature, all that stuff. Complete receptor cells, these are little miniature neurons, and these are actually part of your special senses. These are made up of very unique looking sort of mini neurons. Here's free nerve endings here. So those are these are general and these are special senses. These are specialized neurons that have different structures, and basically when they get activated, whether the little hairs have receptors that bind to odorant molecules, taste receptors bind to chemicals, taste chemicals, odorants, whatever they are. Hearing, there's little hair cells inside of the cochlea. They actually get bent and they fire an action potential. All of these fire impulses, they fire action potentials. Okay, these are part of the special senses, those are general senses. And I always get people say a lot, 5 special senses or 6, and they include somatosensory, they include touch. That's not a special sense. Okay, I want you to keep that straight, because I had an argument with my daughter about this the other night, shaking at me. Skin is a special sense, touch. No, it's not. That's what my instructor said, and your instructor's wrong. Some people do lump it in, but it's not. The special senses are confined to the head, and they use special neuron receptor cells. All the information that comes into your head and your face, those are your special senses, not touch. Touch is a general somatosensory sensation. All right, so, and these general sensory receptors throughout your whole body are distributed all over the place. They are nerve endings that basically monitor all the different stimuli out in your body and your face and everywhere. Touch, pressure, vibration, stretch, pain, temperature, and proprioception. And we've talked about proprioception, right? Stretch out of the muscles and the tendons so you know where your parts are in space, right? Where your body position is, basically. Those are all general receptors, sensory receptors. And there's a whole bunch of different types out in your skin. You've got unencapsulated free nerve endings, so pain receptors. You've got modified little tactile ones that are covered in little structures. And then you've got hair follicle receptors, again, free nerve endings that wrap around the base of the follicle. This is how you know when your hair is yanked, right, or pulled or stuck on something. Activates those little free nerve endings that are on your hair follicle bulbs. You have encapsulated types that actually have little specialized epithelial cells that wrap around them to kind of protect them. You have tactile Messner's corpuscles, that's an example. They discriminate between pressure and light touch and vibration. Lamellar corpuscles, or Pursinia, a lot of people call them Pursinia corpuscles. These are mechanoreceptors. They monitor pressure, stretch, vibration out in the skin. And then again, you have Ruffini endings, so mechanoreceptors, pressure, deep pressure, stretch. All these different things are out in different places out in your skin and out in your periphery to allow you to take in all this information and make sense of it. It all goes to your brain. Some of those are shown here in this block of skin, right? So we have tactile corpuscles right up in the top part of the dermis. We have lamellar or deep pressure receptors that are down further in the dermis. And then bulbous corpuscles that are also monitoring pressure out of the dermis. Hair follicle receptors for movement and deflection of the hair follicle. What else? Free nerve endings that go all the way up. They go through the dermis and into the epidermis that monitor pain and temperature. So those are the most distal ones out in the skin, up in the furthest most reaches, going beyond the dermis and up into the epidermis. These are all different types of general somatosensory receptors, giving your body, your brain, information on pressure, touch, vibration, temperature, pain, all those different things. Proprioceptors, these are important because there are 3 different major types, and they allow your brain to detect position and stretch and movement of your body. So they measure the changing length of your muscles, muscle stretch. These are embedded in the paramecium between the muscle fascicles, those little packets of muscle fibers. We call them muscle spindles, and I'll show you what they look like. We also have Golgi tendon organs. Those are located near the muscle tendon junction, so right near the edge of the tendon, hence Golgi tendon organ. Those monitor stretch or tension within the tendons, so how much the tendon is stretching. And then you have joint kinesthetic, so movement of the joints receptors. These are sensory nerve endings within the joint capsules. So remember your synovial joints have fibrous capsules and synovial membrane interline inside there. You have inside the joint capsules, you have these joint kinesthetic receptors, and they monitor stretch and also pain inside your synovial joints. Here's an image showing inside, wrapped in that little paramecium, they have this individual muscle spindle receptors or muscle spindle fibers. These are a type of proprioceptor, monitoring stretch of your actual muscle. Golgi tendons embedded down in the tendon, monitoring stretch of the actual tendon. And then the joint kinesthetic are in the synovial, in the articular capsule of your synovial joints to detect pain and stretch. So that's showing these proprioceptors, the 3 different types I mentioned, where they're located, how they function. So whenever you see proprioceptor, that's stretch or movement of body parts, right? Mechanoreceptors means it moves, it gets activated when it's stretched or pushed or moved. So mechanoreceptor, okay? So whenever there's movement, it actually triggers an action potential. Okay, so, and I have no clock, so someone's gonna have to tell me. Okay, thank you, perfect. Special senses. My daughter grubbing out on some cake and being super cute. So special senses, sight, hearing, balance, taste, and smell. You have specialized sensory receptors that are localized to the head. These are specialized little neurons. They're like crazy looking neurons, either in your ear, in your vestibular apparatus, your cochlea, your retina, the back of your eyeball, your tongue, or your nasal epithelia. That's where you have all these cool receptors. They are not free nerve endings of sensory neurons. They are actually complete separate little receptor cells, little neurons themselves. And that's what distinguishes the special senses from the general somatic sensory senses. They're special receptor cells, they're neuron-like, they transfer information to other neurons in afferent pathways that lead to the brain. You've got rods and cones in the back of your retina. Those are your photoreceptor neurons that detect light. You've got hair cells in your cochlea. Those are the neurons that detect pitch or sound frequency inside your ear. So these are specialized, confined to the head. The eyeball is actually one of the most important, or vision is one of the most important special senses, right? A lot of your brain processes your eye, what your eye is seeing. So 70% of your body's sensory receptors are actually located in your eyes. That means densely has a high population of sensory receptors to detect this information. And almost half your cerebral cortex is involved in processing visual images. So vast area, huge, almost half your brain processes what you actually see. That's my son's little eyeball. Only 1/6 of your eyeball surface is visible. So the whole 5/6 of the back of the eye you can't even see. Okay? You're only seeing the very kind of slit through the very front. You've got eyebrows, you've got eyelids, we call those palpebrae. Okay, those meet at a medial and lateral angles, or canthi. And then you have a little lacrimal caruncle. This is that reddish little elevation of tissue right in your medial canthus. You have that little red puffy little section of tissue and epithelium that's right there. And then you have a little connective tissue within the eyelids called tarsal plates. So palpebra, and underneath those you have the tarsal plates. If we look at it, so you have your little tarsal plate inside here, the palpebras, the actual eyelids with eyelashes and eyebrows to protect and prevent debris from getting in the eyeball. You have the cornea, which is the clear surface in the front, the sclera is the white back here. There's a whole membrane that is attached up under the palpebra and covers the eyeball, and that's called the conjunctiva. Conjunctiva, thin epithelial layer, basically like a sheet that covers the whole front part of your eyeballs, tucked up under your palpebra. If you've ever had conjunctivitis, that's pink eye. Remember I told you my daughter, they thought she had spinal meningitis, but it was pink eye. Basically bacteria gets in here and invades and infiltrates the conjunctiva, right? And so it makes excess fluid production, it gets pink, you know, you get dilated capillaries in there, and it gets really itchy and watery. You guys ever had pink eye and you wake up and your eyes stuck shut and you have to like pry it open with hot water? Anybody ever had that? Okay, so that's infecting the conjunctiva, this protected membrane that goes right in front of the eyeball. I think I'll stop right there. There was a question?
No, honestly, I had.
You had pink eye, okay, got it. All right, so that's what we'll wrap up. We'll continue with this, and we will start the heart and cardiovascular system on Monday. And be working through your study guides too, okay? Yes? Hopefully this works the whole time. We shall see. Oh, just, yep, there's my alarm.